So yeah, thanks for having me today. I'm Dr. Roland Engelbrecht, like I said, and here to present to you on the pharmacotherapy for alcohol use disorder. I just want to give credit to Dr. Jeff Harris, who did a lot of work on this, and I adapted some of his slides. So I have no commercial interest to declare, and I will mitigate any potential bias by providing evidence-based information. If I refer to something that's not evidence-based, I will say so during my presentation. So, alcohol use disorder. So since the DSM-5, it's got a new name, a new standard of care, and dramatically better outcomes. Now, unfortunately, the new standard of care isn't actually that new, which I'm hoping to elaborate on. Our learning objectives today. So, I want to discuss standard of care for treatment of alcohol use disorder, determine what issues might be keeping people from accessing the best AUD care, and develop greater compassion and hope for people with AUD and become a champion for this new standard of care. So I'm hoping to achieve that by then. I will be focusing on the BCCSU's guideline and their one-pager. Some of you might already be familiar with this, but I'll circle back to it. But to start off, so I graduated in 2008, not too long ago. And even then, alcoholism was treated with willpower, counseling, and anti-abuse. So what has been going on? Has anything changed? And for the longest time, I didn't think much changed up until about 4 or 5 years ago. Actually, in 2014, there was an article in the JAMA where they reviewed 122 randomized controlled trials. And they looked at 3 approved meds and 23 meds that were off-label, and concluded that there was a lot of evidence to support the use of pharmacotherapies in alcohol use disorder. So why isn't it being used if there's so much evidence for it? In 2004, articles showed effectiveness of acamprosate. 2006, Naltrexone was shown to be very effective. 2010, Naltrexone depot. But even as early as 2001, the Lancet published a study on the effectiveness of topiramate for the use in alcohol use disorder. And the evidence for anti-abuse dates back to 1949, and it's still being used and really not the most effective treatment for alcohol use disorder. Now, since then, we've looked at Gabapentin, Baclofen, Ondansetron, and Champix. Now, Baclofen, Ondansetron, and Champix didn't make it into the 2019 guidelines, but just to give you an idea that there are medications they've looked at, and there's ongoing research in the field, so just keep an eye out for what is coming in the future. Why this is important is that 10% of British Columbians have alcohol use disorder. That's 400,000 people and their families, and less than 3% of them are being offered any treatment. A third of all suicides involve alcohol, and 7% of people with alcohol use disorder commit suicide. And more than 20% of all acute care beds are used for people suffering with alcohol use disorder. So very, very prevalent problem. The goal of care traditionally has been abstinence. And if you fail at abstinence, you try abstinence again, and then you try it again, and then you try it again, and try it again, until you're tired of trying it, which is not an effective way of treating any disease. Goals of therapy now, abstinence is a goal of therapy and can be for people, but more than that, decrease in drinking days, decrease in heavy drinking days, decrease drinks per heavy drinking days, decrease in drinks per week, or in order to just be able to access counseling and get your life back. So where the previous standard of care might have been abstinence and counseling, it encompasses a whole lot more, and it's more patient-centered. Now, it's important to know that with alcohol use disorder, twin studies indicate a propensity to develop alcohol use disorder, and about 50% is related to life experience, and about 50% roughly to genetic influences. And these life experiences can be abuse, PTSD, traumatic brain injuries, and a disconnect from family and culture. And very important when dealing with people with alcohol use disorder is to really have practice trauma-informed care, and not fall in the trap of just looking at stigma when you see these individuals. This impacts the course of the illness and can help actually inform medication choices. It is a very heterogeneous disorder, and consequently, a plan of care is specific to each person. So I will go into the 4 medications next, and I'm really just going to highlight some points because there's a lot of information on these slides, but I'm going to highlight some things and just tell you what I think about when I think of prescribing these medications. So our 2 first-line choices is naltrexone and acamprosate. And naltrexone is an opioid antagonist, and it decreases that euphoric effect that someone might get when they're drinking alcohol. And it's been very effective. It's shown to be very effective in reducing heavy drinking days. Now, naltrexone should not be prescribed if there's acute hepatitis or liver disease. Should be cautious about that, or if someone's on an opioid medication. It can have some GIT side effects, which can be mitigated by starting the medication slowly and titrating up slowly, but not as slow as you might think. And then uncommon, I don't see it as often as nausea, headaches, and dizziness. A typical dose is 50 milligrams once a day. Can go higher, but it's typically 50. And if you start it slow, 12.5 BID for 3 days, and then increase to 25 for 2 days, and then up to 50, that's usually tolerated really well. Then moving on to acamprosate. So acamprosate works in your GABA receptors, and the way I think about it, it prevents you from taking that first drink. So it really helps with cravings. You need to be 3 days sober before starting the medication, or that's recommended. And make sure the patient doesn't have any renal impairment before they start. It is a bit of a trickier medication to take because it's 2 tablets 3 times a day. Very funny dose, 666 milligrams 3 times a day. So it's kind of easy to remember that. But for some people, taking medication 3 times a day can be a bit of a barrier. So just keep that in mind when prescribing it. Important to note that for both naltrexone and acamprosate, it will be covered by Pharmacotherapy if a prescriber completes a collaborative prescribing agreement. And we can link that in the emails that we send back to you afterwards. But then medication is fully covered for the patient and they don't have to pay for it. Next is topiramate, which most of you may be familiar for other uses, maybe chronic migraines, seizure disorders, maybe some mood disorders, but very effective as well for alcohol use disorder. And I would typically like to use topiramate if either they failed your naltrexone or acamprosate, or if there's a mood disorder like PTSD or associated stimulant use. I've found topiramate to be very effective. You need to be careful if a patient has any vision disturbances because it can cause glaucoma. And if you prescribe it to a female, make sure she has good contraception because it can be fetotoxic. You need to titrate the dose slowly because it can cause dizziness and fatigue and problems with concentration. So typical starting dose is 25 milligrams once a day, and you increase it by 25 milligrams weekly. And typical dose is around 50 milligrams twice a day, but you can even go up to 300 milligrams a day, but that's a very high dose. And most patients do really well on the lower end of the dosing that I've seen. Next is gabapentin. It's got a well-described safety risk profile. I like using it because you can use it during withdrawal management and then continue it after withdrawal. It helps with that post-withdrawal mood dysregulation. If someone is having trouble with sleep, I like adding gabapentin. And what I like about gabapentin is adding it to say naltrexone. I find that the combination works well. So medications can be used in combination if you know the mechanism. So can be, like I said, can be quite useful. Dosing is 3 times a day, and your target dosing is 600 milligrams TID. You want to start it off slowly and titrate it slowly over 3 to 5 days by 100 to 300 milligrams. If you do it too quickly, people feel dizzy, lightheaded, can feel nauseous, and can cause ataxia. So really want to be careful with the titration. Some individuals will tolerate a bit of a higher dose to start with, but If you're unsure, just start low and titrate slowly. So maybe just how to summarize how I think of these four medications, even though naltrexone and acamprosate your first line. I would think of naltrexone if someone's, say, a binge drinker and you want to reduce heavy drinking days, you can start it while someone's still drinking. I would think naltrexone. Acamprosate, if someone's goal is sobriety and they've been 3 days sober, you can start acamprosate. Topiramate, if someone's using stimulants with their alcohol, I would think topiramate first, and gabapentin can be combined with naltrexone, or if you want to treat some mood dysregulation and insomnia with that, I would think of gabapentin as well. So one of these medications can help someone with alcohol use disorder. I haven't really come across someone who does not benefit in some way from these medications. I like to choose a medication that will most likely work, but if the first medication doesn't work, you can try the next most likely medication to work. And like I said, you can use a combination as well. And yeah, spread the words that these medications do help. It makes a big impact on people's lives. And just some references if you want to look up anything I've talked about. That's it.